Hello, everybody. So I am Gina Genova. I am one of the librarians here at Kornhauser. I'd like to welcome everybody to Wellbeing, Risks, and Resilience, Recognizing and Addressing Challenges to Emotional Health. Now, before we introduce our lovely guests, I would like to take a few minutes just to take care of some housekeeping things. So first of all, we would like to remind everybody to mute your microphones. Please rename your Zoom title to your full name. And if you have any questions, the way we're going to be doing that for this event is that we would like you to place them in the chat. And then once our keynote speaker and our panelists speak, we will take some time to answer those. It's possible we won't get to all the questions that people answer. If that happens, then we will address them later in a follow-up. Now, I would also like to mention that we will be providing CE and CME credit for this event. There will be a survey for you to take if this is something you're interested in. We will provide a link to that in the chat towards the end of the event and in a follow-up email. Of course, even if you don't need CE or CME, we still really encourage you to take the survey. Feedback is very helpful in planning future events. And now I will introduce our moderator, Dr. Abby Beecham. Dr. Beecham is a clinical psychologist with specialized training and experience in healthcare settings. She has spent the past 2 decades training psychology and healthcare professionals in a variety of settings, including primary care, pain and oncology centers, and research. More recently, Dr. Beecham's work in research and development of evidence-based interventions has focused on burnout and well-being in professionals, including healthcare, university faculty and staff, and professional and graduate students. After serving as a co-director of the University of Colorado School of Medicine Resilience Program, she has returned to her alma mater, the University of Louisville, in 2019 as the director of the behavioral science in the School of Dentistry. And lastly, before I officially turn it to her, we've had some people just come in the past few seconds. Very quick reminder, please mute your mics, rename your Zoom name to your full name, and place any questions in the chat. We will be addressing those after our keynote speaker and our panelist. And now I will step back and it's all Dr. Beecham.
Thank you. We are really thrilled that you're coming to join us today. And we appreciate everyone who's worked so hard to put on this event. We're really happy that Dr. Heinz Martin, Vicki Heinz Martin, has agreed to be our keynote speaker. Just by way of background, Dr. Heinz Martin has a BS in nursing and MA in education, an MS in nursing as an adult psychiatric mental health clinical specialist, and a PhD in nursing research. She's been at U of L since 1998. She's a professor and associate dean in the Office of Community Engagement and Diversity Inclusion at the University of Louisville School of Nursing. She also serves as the Director of Community Outreach, Health Sciences Center, Office of Diversity and Inclusion, and is the Associate Director, Center for Integrated Environmental Health Sciences in the School of Medicine. Dr. Heinz teaches at the PhD level. She conducts research. She's published extensively in areas of health equity, cultural diversity, mental health, and community engagement. She has over 100 publications, including 2 books, the Routledge Handbook of Global Mental Health Nursing and Library Collaborations and Community Partnerships. I want to welcome Dr. Heinz Martin. I'm really thrilled to hear from her. And so I'm going to turn it over to you.
Thank you so much. First, let me say I'm very, very pleased to be here. Thank you so much for the invitation. And this is a topic that's near and dear to my heart. I hope that if this is familiar to you, it gives you some areas for thought. If this is new to you, I hope we provide you with enough information for discussion and to trigger you in ways that maybe you hadn't thought about well-being and resilience before. I think for the purposes of the School of Dentistry's CE, I have to make this statement, which is neither I nor members of my family have financial or commercial interest to disclose relating to the content of this presentation. I think I've done my duty in that area now. First, I'd like everybody to be on the same page in terms of the objectives. There are 3 of them here, and for the purposes of this particular session, I will be focusing primarily on objective 1 and 2. And our panel will be able to explore what they know in their areas of expertise in objective number 3, as well as making comments on what I have presented earlier in this particular session. Before we get started, I'd like for everybody, and I mean everybody, to think through, you can write it down or you cannot write it down, but think through, how would you describe your level of well-being right now? So think a minute. I'm going to give you a minute to think. Okay, so how would you describe yourself in terms of your level of well-being? Then I want you to think through why you think that's an appropriate designation for yourself. Remember, this is all about what you think. And as you do those two things, I go through my discussion, I'm going to ask you to do some comparisons at certain points in time. But I wanted you to have the opportunity to think about yourself first before we move on. To make it clear what my interpretation and much of the literature interpretation is of well-being, I wanted to put this definition here. It has to do, it says positive state of one's emotion. Remember, well-being, just like mental health, is on a continuum. So we are hoping that everybody is at the positive end, but that does not necessarily define what well-being is. That is the goal. Now, we may have positive or negative well-being. And some of the risks we're going to talk about are very influential into where you fall in terms of that gradient or that range of well-being. It is not only about how you feel about yourself. It's about what you think your meaning is in life, your purpose in life, and to what degree you can exert control and mastery over what you think you should be doing in life or what you should be accomplishing. And that varies. It can be based on religion. It can be based on your comparison to your neighbors. It can be based upon what you thought your goal was going to be as you grew up and got older. All of those domains are relevant to how and where you judge yourself. So as we're looking at that, you'll notice that I'm saying there are external forces that come into play as to how you evaluate where you are in terms of your well-being. And that's an important thing to consider. So we're looking at social context, environmental context, emotions, resilience, and control. All of those things come to play. And all of those things have risks that potentially are involved for each individual. Overall, even though there are many instruments that talk about the various designations that they want to cover in assessing somebody's well-being, there are 3 main categories that are well accepted, and they're all interrelated. You have your global level of satisfaction, how you evaluate yourself in terms of your life. How would I judge myself broadly? Then number 2 is what is happening in a moment that either makes you have positive sense of well-being or a negative sense of well-being. Those are snapshots, those snapshots that occur at particular points in time. The one that's receiving the most investigation and the most emphasis now is eudaimonia. So eudaimotic well-being has to do with the types of things that you can or cannot manipulate in order to get you at a goal, to feel as if you have some mastery or you have some control in terms of your environment, your relationships, those kinds of things. Now, it is becoming increasingly important in terms of helping people build empowerment and resilience, but it is also now receiving global scrutiny in relationship to workplace environments. How does that workplace environment either support or form a barrier to a person's well-being? So you will see a lot of literature on eudaimonic well-being. I'm currently working on a project, and we'll have a publication out related to eudaimonic well-being in the workplace. And lastly, that's been identified as a goal in Europe as one of the EU's goals to support well-being among the various populations, to look at that. Okay, so why is well-being important to begin with? It's important because there's increasing evidence that a person's sense of well-being is strongly associated with their risk for death, or reduced risk for death, or the association of purpose in life being having association with lower cardiovascular risk. So it is not just, we want people to feel better, which is, I'm a mental health nurse. I always want people to feel better. But it also has to do with the quantity and quality of life a person has. So for multiple reasons, this is an important thing. It also illustrates that not one discipline is going to be able to address well-being. It's going to take a combination of experts and their skill set and their emphasis on prevention and health promotion in order to have well-being be the needle on well-being being moved. Okay, so if we're saying there are multiple factors that affect well-being, then there are multiple risks. There has to be. So those risks to well-being can be societal, they can be individual, they can be environmental, but that illustrates the need for a multi-pronged focus on well-being. So let's do another self-check, because we're going to be talking about something that you'll be comparing yourself to the populations that I'm going to talk about, okay? Let's think about specific things that you think influence how you identify your emotional level of well-being. And we're going to do it in two areas. First, we're going to do pre-COVID, okay? What kinds of things made you feel either good, bad, or indifferent about yourself? If somebody were to say, tell me about what things help you build your self-esteem or influence your self-esteem, what would those things be? Now think a minute. And if you want to, write them down, because I want you to examine those things in light of the rest of the presentation. I want you to do the exact same thing, but think about what happened during COVID. How were those things different? Were there new ones? Were the ones you thought, were they altered? Those things I want you to think about. As we look at well-being, we just said it is influenced by multiple factors. So we're looking at environmental, we're looking at meeting needs and resources. We are looking at the social determinants of health that help a person determine to what degree they have control over their environment, or to what degree they don't have control over their environment. So the intersection between what we learned as Maslow and those three lower levels that were the basic levels of what had to be attained before we could figure out where we were, who we were, and how we felt about ourselves. We also need to look at what are the resources, what are the environmental or social factors that impact our ability to do those things, and then how they interplay and result in a person's level of well-being. The citations I have here have clearly illustrated the interreaction of these things and the importance they have to well-being. Okay, as you looked at, the things that made you feel good about your sense of well-being, let's look at the things that are encountered as risks for minority populations. When I talk about minority populations, I'm primarily talking about ethnic, racial, and religious populations, although I am also going to be talking to some degree about gender and gender identity. So please kind of bear with me on that. Okay, these are the things that underserved and disadvantaged people experience every day. This is not COVID, this is every day. So those things have to do with lower income. They have to do with what type of employment they have, which is at more physical labor. We're looking at whether they have home ownership or whether they're renters, and most minority individuals are renters. They live in communities that may not have the most amenities. They are at higher levels in federally assisted housing or multi-generational homes. And lastly, they are within communities that are considered socially vulnerable. And those socially vulnerable communities experience food deserts, limited public transportation, and limited access to routine health care. Those are the things that exist. So as we're talking about meeting our needs using Maslow's hierarchy and the structures that we need to work with in order to get those needs met, we are already starting at an inequitable position for a significant portion of the people in the United States. In addition to those things that have been well documented, recent and past history has shown the accumulation of experiences that affect the worldview of individuals that have to do with either discrimination or they have to do with histories of trauma. So we've laid those on top of the other things that we've already identified. And those are the routine risks that minority populations experience. Now let's look at the impact of COVID-19. So we've already got what the playing field has been. Let's look at what changed during this period of time. Now, remember, I asked you to take a look at what kinds of things affected your well-being pre-COVID and what kinds of things affected your well-being during the period of COVID. And you saw the differences that occurred. Everybody had some sort of stress. If you didn't have any stress, I want to know who you are, because I'm assuming that everybody was impacted. Well, let's look at the impact for people who already experience inequity. We've again said that multiple disciplines are being affected in terms of what they can do and how this affects what the area of expertise is. So we're talking about healthcare, we're talking about economics, we're talking about resources, whether they are just community resources or resources related to this pandemic. We are looking at a better understanding of how the social determinants are being managed by those individuals who are at a disadvantage, both routinely as well as during this special set of circumstances. So everybody who potentially is part of this session has a bit of skin in the game in terms of how we're going to make things different. So let's look at COVID. Okay, there's differences in exposure. Those differences in exposure have to do with the things we already talked about. Multifamily housing. We've got people in close proximity. We've got people at lower levels of employment that are now considered essential workers. They didn't get any more money, but they're essential. So they have low pay and high exposure. Then we have women who are affected disproportionately in terms of lockdown. We have no daycare and schooling is now at home. We have communities that have food deserts as well as supply deserts. So the things we said people had to have were not readily accessible. Masks and sanitizers, food to stock and toilet paper and those kinds of things. So it was even harder for them to get the things that they needed. As schools had to be done at home, then many of the people who are disadvantaged had no Wi-Fi in order to do what was considered non-traditional education and instruction. So they are, again, at a higher level of disadvantage. There's differences in resources, and those are limited there, and with the most important one being limitations in funding. So what does that mean for how life is treating them? Well, look at the hardship and the relative hardship based upon what ethnic or racial group you belong to. As would be expected, those who have lower income and those who have fewer resources are suffering more. And unfortunately, Latinx and Black people are higher on the list there. If we're looking at the worries and the stresses people are experiencing, if you'll look at funding, how much money they have, which we've said already, the minority populations have a lower level of funding, you'll find that those who make less money have higher stress. That's a no-brainer. And then it is later expressed in more worry and stress. So we begin to look at meeting the needs of their family or themselves, their mastery and their control for those things being lowered, and therefore their ability to manage that being impacted by symptoms of anxiety and depression, which therefore impacts their sense of well-being, which makes sense. The effect of inequality or inequity also affects by age and women. Younger adults are more likely to be in essential worker status. Women are more likely to be impacted by the shutdown. So we end up with people that are younger, that are women, being more adversely impacted. If you also look at, they're more likely to be worried about a family member. Remember, social interaction is one of the few things that, regardless of your economic status, is seen as a strength. However, during this period of time, people were separated. And so the strength that they once had in an already disadvantaged world is now gone as well. And that had a very strong impact that people might not necessarily have recognized in terms of worry about family members being sick or making it through the virus. So if we're looking at all of those things that impact well-being, we understand that there are things that are fluid in terms of well-being. There are some things that are fixed, and many of those things that are fixed are the sources of risk that impact an individual or a family. And therefore, how we support their resilience and their ability to respond to those types of things should be the focus of what we do, regardless of what our discipline is, if we are trying to affect a change, overall change in the environment in which people exist. There are multiple factors, which I just pointed out, that affect well-being at an individual, cultural, and social level. We have people who are in the audience who function and focus at each one of those levels, and therefore have an important or key role in helping us come up with strategies and resources. Literacy about well-being is not just for the public. Literacy about well-being should be focused in on our professional groups, so that we understand not just to measure well-being, but to look at well-being as being something that is that we can intervene in. But we can only intervene if we understand what those influences are, especially for those who are disadvantaged within our society. Emotional well-being must be considered in all settings. So regardless of the type of healthcare you provide or the area of health influences you study, how does it affect a person before they get to the end, before we have the most negative effect, which is mental health problems and concerns? How do we build into our systems exactly the types of resources and supports we need to do in order to make people more able to be empowered and resilient and feel that sense of control. Because well-being is subjective. So much of what we want to do has to focus on how does that person perceive their ability to cope, their ability to master, their ability to meet what they think their goals are. And those goals are different for individuals. Some of us, are in universities, and some of us are doing day-to-day work. However, all of us have goals that we want to attain. And we need, as healthcare providers and those in the area of environmental change, need to look at what is it that's the priority for that individual, and how can I support them in their ability to do that. So I'm going to turn this over to our panel, and they're going to give us some resources and their feedback on what it is we think we should do. Please be reminded that questions can go in the chat, and after our panel has their discussion, we can then respond to your questions. And if we don't get a chance to respond during our session, we'll make sure we respond subsequent to our session. These are some of the references that I utilized during the presentation. If they weren't already on the slide, these are the additional ones. And these are some of my publications that have to do specifically with either social determinants, well-being, culture, cultural variations, and underserved populations. Thanks for your attention, and I'll turn it over.
Thank you, Dr. Heinz Martin. What we'll do now is we'll go back to a gallery view so that we're able to see the panelists who were here today. And so if all the panelists would maybe turn their camera on, that would be great. Okay, we'll be taking questions in the chat. We have some people here on our end who are going to be reviewing your questions. I'm going to go ahead and just very briefly introduce each of our panelists who bring a unique perspective to the topic that Dr. Heinz Martin was just discussing with us. I'll start with Mike Udo, and he is a third-year medical student here at the University of Louisville, as well as a founder of Grow 502. He completed his undergraduate education at Indiana University, followed by obtaining an MBA and a master in physiology here in Louisville. And he'll be able to give us some unique perspectives from the viewpoint of someone who is currently a learner, but also a healthcare provider. Secondly, we have Holly Cunningham. Holly is currently serving as the mental health coordinator at Kentucky Refugee Ministries. She received her BS in elementary education and sociology and her master's of divinity before moving to Louisville to continue a career focused on trauma-informed care. She has a diverse background in teaching, chaplaincy, sustainability, and nonprofit work, and Holly's passionate about providing holistic approaches to promote mental health and emotional well-being. Also on our panel is Kaylin Shea, and Kaylin is a registered nurse at U of L Health's main hospital. She serves as a charge nurse and a preceptor. She's received her bachelor's degree from University of Louisville in 2019 with a minor in psychology. And during her undergraduate studies, Kaylin served on the executive board of several student organizations and was awarded the Faculty Award for Professional Nursing by her professors. In August of 2021, she returned as a student at the University of Louisville to pursue her DNP, which I believe is the Doctorate in Nursing Practice. Is that correct, Kaylin? And she has a specialty in psychiatric mental health nurse practitioning. I want to start, we're going to go one at a time with each of our panelists. They prepared some comments, and they'll be taking somewhere in the vicinity of 5 or so minutes, maybe 10 minutes, to talk about perspectives, to jump off of what Dr. Heinz Martin has been presenting. I want to remind you that you can put your questions in the chat. We'll be going through those on the back end, and hopefully we'll get to all of your questions, and I'll be moderating and directing the questions as best I can to each of our panelists and Dr. Heinz Martin. So Kaylin, why don't we start with you if that's okay with you, and we'll turn it over to you.
Hi, everyone. So thank you for allowing me to be here today. First, I wanted to say that I and or members of my family have not had any financial or commercial interest disclosure relating to the content of this presentation today. So I wanted to talk about emotional well-being and how it relates to my job at in the inpatient psychiatric unit at U of L, and how that influences the patient population and some of the things I've seen through my practice here. So on our unit, we typically get a lot of patients experiencing sort of disequilibrium in their mental health. And like Dr. Heinz Martin said, your emotional well-being can impact your mental health, which can in turn impact your physical health. And it's important that we recognize sort of these root causes and these social determinants of health that place people at a higher risk to impact their mental health and ultimately their physical health. And like Dr. Heinz Martin said, I think we had the same definition of emotional well-being, and that it's an overall positive state of one's emotions, life satisfaction, sense of meaning and purpose, and your ability to pursue your self-defined goals. So this kind of reminds me of the nursing theory of self-efficacy, and how if you have this sort of idea that you can accomplish this kind of like state of equilibrium or emotional well-being, that you're more likely to have positive outcomes. So I think it's important that when we interact with our patients, we sort of get an idea and screen them for anything that may place them at a higher risk, whether that be fixated factors like their race and ethnicity, their social status, and their location or where they live, things like that, that could place them at a higher risk for vulnerable outcomes. Typically, most of the patients that I see are in a vulnerable state of mind. Usually their mental health is poor, but also you have to get to the root, which is their emotional well-being. And I found a study that talked about, it was a roundtable done by the National Institute of Health, and it kind of talked about how your emotional well-being is correlated with your physical health. So things we can do to impact our patients' emotional well-being when they're here on the unit is we have an atrium on our unit, which is sort of has like a glass ceiling so you can see the outside, because most of our patients can be here for long periods of time. They aren't going outside, and we know that like vitamin D and sunlight positively impact our mental health. And so we have an atrium that it has music, and we have like calming music that we play on the unit that can help sort of bring down agitation or anxiety that people may be experiencing. Something special about our unit compared to the rest of the hospital is that we have private rooms for our patients. And this can be helpful because sometimes when you're having an unbalance in your emotional well-being and you're in a room with someone who's having a similar issue, you can kind of feed off of each other, or the anxiety can be contagious to you guys. So having semi-private rooms is also another benefit of what we provide on our unit. Some of the threats that I see to well-being in our patient population would probably be poor support. So because these patients are undergoing sort of a mental health crisis, this is kind of like a last resort for them. So some of them, they don't have access. And so that's something that needs to be addressed is the resources that are available to our patients when they're not in the hospital setting. And some of them, their lack of access is so extensive that there's only so much that the hospital can do. And, you know, some of them, they don't have social support, they don't have family support, they don't have a home, they don't have an address, they don't have a driver's license. And all of those things can impact, can they get their meds when they get discharged? Are they going to have a home to go to when they get discharged? And those are things that we try to work on while they're in the hospital. Typically, we try to discharge our patients to either like a facility, a family member, or some other location. That way they're not just kind of thrown out on their own. And so that's why most of our patients stay here for pretty much a decent length of time. On the unit during the day, we have therapists on the unit and they talk about coping skills. We have music therapy, we have art therapy. Occasionally we have yoga, and our patients are encouraged to interact with each other, because I had a patient just last night tell me, I feel like no one cares about me and nobody loves me. And so it's good for our patients to go to these group therapies with other people who are experiencing similar aspects, and peer support groups are beneficial. And the evidence-based research has shown that. And that can also positively impact our emotional well-being and in turn impact our mental health. I have noticed that lots of our patients, sometimes they lack positive coping skills, and sometimes the support that they do have is not beneficial support to them necessarily. So sometimes they have friends who have poor support skills and poor coping skills, and in turn, they engage in those poor coping skills as well. And it impacts them differently than it impacts their friends, and it can impact them to a higher rate and a higher extent. Some people on our unit have poor insight into their mental illness. And I think this goes into the topic about this goes into the topic about how the stigma associated with mental health, and how some people, they don't want to admit that they have a mental illness, or they don't want to talk about it, and they sort of just deny it altogether, and that can negatively impact our patients' emotional well-being. But on the unit, we work as a multidisciplinary team between nurses, psychiatrists, case managers, social workers, therapists, pharmacists, so that we can correlate and work with those other resources in the community, so that our patients can have better outcomes and lower hospital admission rates. So that's all I have to say. Thank you.
Thanks, Kaylin. We'll turn it over to Mike and hear a little bit about your perspectives.
So good evening, everyone. So I kind of bring a very unique perspective when it comes to this topic, because I'm in my third year of medical school. And as some of you may know, the third year of medical school is the first year where you're actually applying a lot of book knowledge to actually seeing clinical and patient experiences. So with these experiences, well, first was with the clinical knowledge, when we go into our medical school third year, we spend like 4 to 5 weeks on big systems like cardiac care and pulmonary and renal, GI. We spend so much time on neurology, all on these bigger concepts. But then when we get to psychology and mental well-being, that's actually one of our shortest topics. It gets the least amount of time, and it doesn't get a really in-depth conversation. So as a person finally entering my third year of medical school, when I'm thinking about emotional well-being and wellness, that perspective is from an extreme. I see it as psychosis. I see it as some of the rare cases of bipolar disorder, mood disorders, anxiety disorders, panic attacks. These are the things that I think of as emotional well-being as a future medical provider. However, we don't talk about the disequilibrium as it comes to like baseline, just small amount of anxiety, or just let's say, anger, or just like the small aspects of emotions that people can sometimes not be at balance. So it's really challenging from my perspective as I get older and continue to become more focused and streamlined in my approach to medicine to truly understand emotional well-being, because how I see it and how I'm being taught of these concepts is from the extreme. I'm expected to know when someone's is going through a psychotic break, or when someone's being manic, or when someone is truly at an emotional extreme where they need medical care or need to be provided a drug or prescription. So that's, that, and when we're talking about our patient populations, that's where this conversation gets tricky, because if I'm only expected to know the extremes, then who's expected to help you learn how to cope with patients who have just smaller issues with their well-being? And it seems like that's all being pushed on psychiatrists and like psychologists, and just a very small population of the bigger pie of which is healthcare. So now as a third year, I'm looking, when I have conversations with patients and I'm kind of in the background, kind of shadowing or kind of like watching how medical providers have conversations with their patients, we don't really talk about these small little aspects, not small at all, but these aspects of well-being, because we're only looking for the extremes. Like, are you having suicidal ideation? No? Okay, you're checked, you're covered, you are well, which we know that's not the case. So for me, I think there's one approach that I would love to bring up about this conversation, and it's using techniques to help facilitate our very limited time to get a better idea of people's well-being. And I was doing like research in a topic because I was interested. The one big constraint on all providers, on all healthcare practitioners, nurses, anyone, is time. So how do you efficiently, in the small time you have, practice and get better at trying to get a better assessment of a patient's well-being? And what I found was the BATHE technique. And BATHE stands for background, effect, troubles, handling, and empathy. And those 5 letters kind of spur 4 questions on one statement. And the first question for background is, just tell me what's going on. And I think that simple question of asking someone what's going on in your life can kind of get people to see like, okay, they're interested, or they're kind of invested in my well-being. Let's see, they might not divulge, but some people might, because people don't ask that question. It's only maybe your close loved ones or people who you're really close with, you actually check on them. But if we practice this more, maybe we can start to get better. So just asking someone the first question, the background, tell me what's going on. And then moving on to the affect, your emotions. How do you feel about it? Moving forward from how do you feel about it, what troubles you about it, the T of bathe. And then H, how are you handling this trouble? How are you handling your emotions? Finally, finishing with E, which it's empathy, just a simple empathetic statement like, I'm sorry you're going through that. And the reason why I bring up this technique is because since we don't practice kind of getting to know people's emotions and getting people, seeing how people are doing with their well-being, we're never going to get better at it as a provider force. We're never going to be able to focus on trying to help eliminate these sources of disequilibrium that's affecting our patient population. And this technique only takes like 5 or 10 minutes. It's something that you can employ with a family, a friend, and hopefully start to use it with your patients and different people you see. Because I think what we're going to find is that we're going to see a lot more people are actually in this state of negativity or in this state of doubt or kind of emotional decline, that if someone would reach out to them earlier, they might have been able to help persuade or dissuade certain courses of action or certain maladaptive behaviors. Because something that we do know, which is science, is that stress leads to maladaptive behaviors. It's just a common practice. I know when I get stressed, I immediately go and eat something or try and accommodate my feelings with some candy or something, which is not a good thing. And I'm not sure how many dentists are here and they're probably appalled by that, but that's just what I do. So we're gonna move forward. But that's the one aspect of it, is because, okay, I'm bringing up this new technique of using a bathed interview style to hopefully address people's emotional well-being. But what happened over this past 1 or 2 years is that we have gone into such social isolation that people aren't able to even communicate effectively with one another. Simple interactions that were, common that we've learned since children have become a little awkward. Just even shaking someone's hand, you have to think once, is this okay? Is this not okay? Can I shake your hand? Are we at that place yet in our COVID pandemic? But because we've lost this ability to social communication and social interaction with one another for the past year and a half, we're not even thinking about having regular conversations and being able to do things like this. So, and social connections is a huge factor in emotional well-being. In the NIH Emotional Well Kit that they publish on their website, social connections is like top 5 of things that are super important in assessing someone's emotional well-being. So obviously we need to come back together as communities to do things like this. And one way I'm doing this, and a lot of medical students and younger students, is through Grow 502, which is an interdisciplinary organization focused on health disparities. Is we're trying to get back out in the community. This huge stoppage in us being with the people who need us the most, for example, the West community and refugees and homeless, they haven't seen us in a while. So now that we're going back into those spaces, we need to be able to use techniques like this to hopefully start to, reduce that divide that we have. Because as a whole, I think we're all seeing that things are a little bit wild. Things are a little bit not the same since COVID has happened. So with that being said, we need to find a way to approach our patient with social interactions. When we get there, start asking questions that may seem awkward at first, but really it's a tried and true technique of breaking down people's barriers to have healthy conversations. Because mental health and well-being is not about having serious psychological disorders. It's just like disequilibrium in emotions and feelings that can be addressed earlier, but sometimes we're not attempting to address it at the start. And we're only, from my perspective and the medical community perspective, sometimes we're only waiting to see these huge extremes. That's not necessary at all. I think if we start to approach it from, hey, we need to practice asking questions, being more connected with one another in small ways, we'll be able to do that in bigger ways with patients and so forth. So yeah, that's all I have to say right now.
Thanks, Mike. Now we're going to hear from Holly Cunningham. Just as a reminder, Holly is the mental health coordinator at Kentucky Refugee Ministries. And so Holly, what are you seeing in your community, and what thoughts do you have with respect to the topics that are being discussed today?
Yeah, thank you all for having me to be on this panel today. I think these are some really valuable perspectives that kind of, as Mike was just saying, like we need to talk about more on the forefront and along the way as we interact with people in our community and in the places that we work. And so from my place of work, working with refugees and immigrants, we, address emotional health and well-being every day. As you can imagine, a lot of our clients who are coming from all across the globe have experienced a lot of different kinds of traumas. Certainly folks coming from countries that are experiencing war or civil unrest can be very traumatic, and also people's time spent in refugee camps or detention centers, just trying to get from what has been home for them to a safer location because it's no longer safe to be in their home. Even just that act of having to leave home can be very traumatic. And so the overall, emotional, physical, social well-being of our clients is deeply impacted. And we see a lot of trends of people experiencing PTSD, kind of extreme depression and anxiety, some isolation. It can be very hard for folks when they're coming into a place where they don't speak the language and they don't know people here. Some of our clients are lucky to be resettled where they may have some friends or family already in the area, but plenty of them, come here or elsewhere in the United States and really don't know anyone. And so making those connections can be particularly hard when, you don't speak the language, as I said. And then there's lots of minor barriers. So imagine being new in a country where you've had to come kind of in a crisis situation. So finding the ability to work or get income or housing, transportation, like everything is new. And there's a lot of barriers in each of those avenues too. And so something that we do as a refugee resettlement agency is to help people find those things. So we help all of our clients find housing. We connect them with healthcare providers, try to get them insurance, things like that, and just teach them kind of the basics of being in this new space where cultural norms are different, practices are different. And that can take some time to adjust. So a trend that we often see is when clients first arrive, there's kind of what we would call like a honeymoon period almost, where it's like, okay, I've reached safety, like, you can feel good and excited. And then all of these other things start coming up where you're like, oh, I don't know how to do this yet, or I don't know how to navigate this. And it can be very frustrating and overwhelming. So there can be a big dip in people's overall well-being as they face those barriers. And so really something I would encourage anyone to do is, if you see people in the community or at the place where you work, and clearly they're struggling with the language or maybe confused about something they're doing, is to even just take the time to like pause and say, I see you, I hear you. You might not be able to communicate in the language that they're speaking, but people often just kind of turn a blind eye and walk away. And that can be really overwhelming for our clients too. So something I do in my role as well is to talk with clients to kind of assess what are some of the mental health and emotional well-being issues or barriers that they're facing. Do they need to find a counselor or a support group or some sort of professional? And so I will refer clients all across Louisville to many of our fabulous community providers who have access to language lines, which is a tremendous thing in the hospitals where our former panelists were speaking from, that people can always access the language line. And it just makes a world of difference when someone finds the ability to communicate and just to even say what they're going through. So this is something that I think I'm constantly doing education on providing like culturally competent and appropriate care, using interpreters. And so I think the more that health and mental health providers are learning these things, learning about the places that people are coming from, can be really helpful in just building that connection and relationship with clients. And as I said too, isolation can be a big thing or a big issue. And so really just encouraging folks to be able to connect with someone else in their community. Maybe if we know there's another Spanish speaking family who lives in the same building, maybe we can introduce them to one of our newer families who just arrived from Cuba or wherever it may be. And just to help make those connections so someone has someone else they can talk to in their language. We take it for granted every day when we are just out and about and we can communicate with the people that we come across and interact with. And that's really a luxury that not everyone has. Folks are working hard to learn English and to kind of expand their connections, but it takes time. And so another really important thing is just to have patience, to try to listen to where someone is coming from. Maybe they're incredibly stressed because they don't have all of their documents yet and they can't start working. And so they can't pay their rent, but they can't get to work because they haven't learned how to use the bus system yet. And it's like these things pile up very quickly. But at KRM, if we can help them even, okay, we'll practice the bus route with you and, we'll introduce you to this potential employer or whatever it may be, those can be very helpful things. So I think building community, making sure people don't feel that they're alone and isolated, and just finding those ways that we can help people be able to share what they're going through and experiencing is really important.
Thank you to all of our panelists. I want to pose a question, and I'm going to start posing this first to Dr. Heinz Martin. As you have questions, please feel free to put them in the chat, and I will be happy to direct them to whomever you have questions of. I have a few here already, and I wanted to start. Dr. Heinz Martin, you talked about Maslow's hierarchy of needs, and we may have each learned that along the way in our training. And at the most basic levels, we have basics instead, in terms of food and safety, and how many of the groups of people who've been most affected historically and through COVID have had the most trouble meeting those basic needs. So here's my question. Some of the recent discussion around Maslow's hierarchy is that people have the capacity through all adversity on those basic levels to also have meaningful experience and eudaimonic experiences, that sense of meaning, the positive experiences, if I'm quoting you correctly. Has it been your experience that even in those hardest moments, we can also tap into that sense of emotional well-being?
I think that's undeniable. If we just talk about the struggles that different populations have had just here in America, if we're talking about our indigenous population, we're talking about African-American population, any population that's come into the environment in which they were at a disadvantage have not only struggled to make sure that they met their needs, but also found ways to find purpose in life. Sometimes it's religion, sometimes it's other things, it's family, sometimes it's heritage. But those are things that keep people going and to get through those struggles and to meet the challenges that they meet every day and those that are extraordinary. So yes, we can do both. But what we do is make it hard for people to get to those levels and clearly explore what their potential is, because they are always dealing with those lower levels of just, meeting the basic needs and being safe. So yes, we can do both. Let's not make it as hard as possible.
I thank you. One of the things that I noticed while Kaylin, Holly, and Mike were talking, they were talking about the little things and how little things matter. Taking a moment to talk with someone, to show someone a bus route. And I'm wondering if when we don't hit that diagnosable level of mental illness, if you will, if we make a substantial impact by having just 5 minutes of the little things that have potential great meaning, what have you seen? And I'm interested in each of the panelists' perspectives on this. So, Holly, we'll start off with you, and then we'll go to Mike and then Kaylin.
Yeah, so I see this every day in my work, truly. Those little moments where you stop and just have a conversation with someone and say, okay, I see that you're stressed about this. Let me just listen and tell me what's going on. Sometimes I can't even fix the issue immediately, but for someone to be heard, I think makes a huge difference. We as humans, we desire connection and we want to be seen and heard and feel that people value us as human beings. And so often, I think, especially with our, underserved communities, it's easy to look at people as less than or to overlook them completely, and to not stop and take the time to just say, I see you. And so I think little moments like that are tremendously important, stopping and saying, hey, I care about you. I was thinking about you today. If we can all make a little more time for that, we know how much it makes a difference to us when people reach out to us. And so I think we can do the same, and promote well-being, across all the different levels.
And Mike, you talked about a brief model, the bathe technique that you've used, but that basically that adds structure to what Dr. Heinz Martin and Holly have just said. Has it been your experience that just taking a little extra time has an appreciable and positive effect with where people find themselves emotionally?
Yes, I believe so. There's been some interesting statements about COVID-19, such as it's been the great equalizer. Now everyone is finally on the same level, when we all know that that is actually definitely not true, and that people have experienced significant traumas at different levels, and people have not coped with it all the same. So during my time, especially this year, being back in the hospital, after a year of being at home and kind of like isolated and learning, but now being thrown right into the fire, to let's say, to learn about how to appropriately treat patients. The one difference between like an excellent doctor I've noticed and just a doctor who's doing their job is a doctor that spends like 5 more minutes, who like changes their tone, has a normal conversation, talks in a way that a patient would like to be talked to, and not use all the medical jargon, and ask, how are you doing? Like, I know this is really challenging. I know you're going through a lot. Seriously, tell me, how are you? And just like watching the way a patient's face change and the way their demeanor changes immediately when they see that the doctor is actually being a person. Like, they stopped being a doctor for like 5 minutes and started to be a person who sees them, has really made like a huge impact in like the remainder of their care. From that point on, the patient is more open to talk about problems. They even start to express things that at first we didn't hear at first. We're like, wait a minute, we didn't know this was going on, but now they feel comfortable, they feel heard. And I think that is something that I've seen like consistently, is that like, and I mean, the doctors here at U of L and Norton, they're all spectacular, but they are also so busy. But the ones who add just like 5 minutes to just like put the books down, the paper down, and just talk to the patient, sit on the bed with them, those patients, they may not in a day do clinically better significantly, but their stay and the way they interact with the rest of the healthcare workers improves. And there's such a change, because it seems obvious to me that they want to talk about these things, but they're not going to just divulge the information by themselves. Sometimes they need to feel more comforted and feel more like you actually care. And I think that does make a huge difference.
Thanks, Mike. Kaylin, I want to direct this to you now. You talked a bit, when you did your introduction, about the things that you do routinely in the inpatient area to help people just feel more, I'm just going to say well, and have that, what Dr. Heinz Martin defined for us as that eudaimonic experience. Can you talk a little bit about what Holly and Mike have said regarding the small moments and the impacts that you're seeing around, not just when we think about mental illness, but around well-being? And then I'm going to shift this to another question I got, which I think will be an interesting way that we connect the dots here. So what have you seen?
So Holly and Mike made some excellent points. And I've noticed that some of the small things that we do in our unit make a large impact. And it can kind of, nursing is fast paced, and we can kind of get in the habit of you're rushing to pass your meds and you want to chart, and you don't have time to sit down and just chit chat. But sometimes that's what somebody needs. I've noticed that a lot of our patients, they just need somebody to listen to them. Sometimes they have these big outbursts that cause them to come to the hospital, but ultimately it's because they're not feeling seen or heard by the people around them. And taking a moment to notice that your patient who braids their hair every day didn't braid their hair today, or they eat ice cream every day and today they chose not to eat ice cream. And noticing just those small behavioral changes or small things that you typically see and they don't do, and bringing that to their attention, say, hey, are you feeling okay? I noticed you didn't braid your hair today. Is there a reason why? Taking a moment, we have games and stuff on our unit, we have movies, and going to play checkers with a patient. You know, you can't just sit at your computer all day. You got to interact with your patients, and you have to sit down and talk to them. Something I usually do is I sit down in my patient's room. So a lot of nurses will stand at their computer at the door, but I find that sometimes the patients feel comfortable if they're just sitting up in their bed and you're sitting down, you're speaking to them at eye level, and you're showing that you have the time to sit down and actually talk, can go a long way with some of these patients, because a lot of times they feel like everybody's just in and out rushing to see everyone else and nobody has time for me, when we really do. Those small moments of time with those patients are very important. And like Mike said, people aren't just going to openly indulge all this information to you. And so sitting down to say, how are you really? We have our assessment questions that we ask them, are you going to hurt yourself? Are you going to hurt anybody else? But it's, do you have any thoughts of hurting yourself? Is there any reason? Like, what are things that you normally do to cope? How can I help you? Tell me what you need from me. And asking more open-ended questions can really impact our patients' outcomes.
Thank you. I'm going to shift this slightly for a question that I got. And this ties into what Dr. Heinz Martin asked us to do, and something that Mike said, and that everybody has alluded to. What do we need to do in terms of recognizing, we are providers, we are teachers, we are people who are working to support other communities. That is demanding work, and we have to be aware of our own well-being. What are some things that you have found to be particularly effective with the people we work with, each other? What are the moments that are important for us to remember for one another? And I'll start with Dr. Heinz Martin, because you talked a little bit in our conversation before we got started about primary and secondary prevention. And I'm wondering what place that has with one another as professionals.
I think we tend to forget that we're just people too, and we're going through this situation, and we have responsibilities that are fairly significant, and they can have an impact on you. I do things that don't seem to be targeted toward making people, they're not targeted specifically for well-being, but that's the point of why I do them. For example, I don't work in a clinical setting right now, but I do work in an academic setting. I work with clinicians, and I work with students, and I work with faculty who teach. I consistently send out things on emails that have just music on them. You'll like this song. Or I will recognize a population or a group because it's something that is notable. I always take every opportunity I can to congratulate people on their accomplishments. When I think that somebody needs to talk, people feel really comfortable coming into my office and sitting and talking, because I like to do that. So sometimes I send it out to a group. Sometimes I target people that I think might have particular issues that you just want to talk about. And I always recognize folks for the hard work that they do. Those are things that you can do to everybody. You don't have to necessarily say, oh, they're at a deficit. It's just the fact that you recognize they're people and they need recognition. So I start there. There are other things I do, but I always start there.
Mike, something you said about when some of the doctors with whom you work actually just stop, sit down, and are a person with patients, you notice a ripple effect with colleagues. And I'm curious to know if you're noticing anything else around students, and how students have been experiencing the demands of COVID, and how they think about their own well-being?
I have noticed one thing in particular about, COVID and its impact on students is that I think we are talking more about our emotions, which is something that normally we wouldn't have in previous to COVID. Going the first year, everyone kind of has their tough exterior where, I came from so and so background and I'm so and so this, and I'm going to be an amazing doctor. And they're all, oh, sorry, I just muted myself.
Okay, I was just going to tell you were muted there. Okay.
Yeah, and now like after kind of going through a year where we just noticed this type of social isolation, and we're studying all these different medical conditions and how just generally um, impacted people are by their health and mental health. I think we now talk more about emotions and talk more about stress because we know we've gone through it. And like every medical student will say that we go through immense amount of stress, but plus COVID has definitely impacted us in ways that none of us really would have thought. So now that we're in this clinical setting and we're seeing patients, I think the one thing I've noticed is that people are more open to seeking mental health services. Our school has done a great job of providing counselors and people we can go talk to. And I've heard more and more students actually going to those, and they're talking about it, which before you would never admit, such a quote unquote weakness. You will never let your fellow student know about that. But instead, we're actually talking about it more often. And it's helping people to go seek that out when they need it. And I think that's an amazing part of it, because it's kind of hard to practice what you don't like, to practice what you don't or preach what you don't practice. You know what I'm trying to say in a day. Because if we all have such an aversion to mental health and say, oh, like I'll never go see a psychiatrist, or never go, how are we going to tell our patients to go do that? But now that I'm noticing that students are going to do that, and like it makes me more open. Just even, I'm not necessarily, I may need to go see some mental health services, but one, now that my colleagues are doing it, I feel more comfortable to do it, as well as I'm more comfortable talking about my emotions and letting you know, like I'm having a bad day, like, and that's fine. Like I'm not happy, I'm feeling stressed, and having that comfort of someone listening and saying, yo, that's okay. Do you need to sit out this interaction with patient? Like I got your back, and just, we're talking more. And I think that's a really huge positive outcome from this COVID pandemic, is that we're more aware of mental health. And it's still going to take some time before it's a standard practice, but because we're more aware, it's helping us to be able to talk with patients about it, and also be able to kind of help each other cope when things come up.
Great. Thank you. And I think a lot of us who work with students might be seeing the same sorts of things. And so I appreciate you saying that. Holly, I want to ask sort of the same thing from you. You work with people who have experienced a lot of trauma, and an area that is particularly important to you, as I understand, is trauma-informed care. Given that you're working with a trauma-informed approach, what are you seeing in terms of the little things that you try to do for one another because of the toll it can take for you in those settings?
Yeah, I think that's a really important question. Trauma fatigue, or compassion fatigue, I guess, but in response to, hearing traumatic things most days. The people who we work directly with have gone through some really hard stuff. And so I think it's vital that we as coworkers and as an organization support one another. And one of the really cool things about working at KRM is that our staff is really diverse, in that folks who work here are from lots of different countries and speak different languages, and bring a really amazing perspective to this place. And so something I have found that's really meaningful for all of us is just getting to know little pieces about people's home, or about their culture or their traditions. And that goes for clients and the people that I work with. So, what's something that you love about home? What's something special about your family? maybe learning a few phrases in other languages that people are speaking around you, like that can go a long way. So I think little things like that, and then just a genuine curiosity and care about the people around you, it makes a huge difference. And it, I think it's not only valuable to others, but for me, like, it enriches my life a lot to learn about all these beautiful cultures that people come from, and the things that they love about their home and the things that they bring here. It's just really incredible when we stop and ask people things, or just listen to even a tiny piece of their story. The things that we learn in here, I think, really connect us. And at work here too, we go out to lunch regularly, just, not as a whole organization, but, a couple people are in the office and we go grab a bite at an ethnic restaurant, or, somewhere where we can also learn about, foods from other places and different things like that. Louisville is a really cool city in that we have a lot of different restaurants and grocery stores and things that represent other cultures. And so getting out there and trying new things in that way, and doing so with coworkers and community, I think is really helpful for all of our mental health, particularly now that we're able to do some of that again, despite the pandemic and the toll that has taken on these things too.
Great, thank you. What I want to do now is I want to, I had a couple of questions that were sent to me. I want to think about the way that we conceptualize well-being, and that it isn't necessarily having a diagnosis. It's sort of that, the subclinical or even the more positive aspects of just how we experience our lives, and the fact that it really is about more of a public health focus. And so I'm going to start with Dr. Heinz Martin, and I want to pose this question to you. How can clinical healthcare providers collaborate with public health practitioners to combat the growing mental health well-being crisis? And I talked a little bit about this ahead of time, but I wonder if you can comment on that, and comment about social determinants of health with respect to public health. Does that make sense? Because I realize I just lumped it all together. So
that's okay, because it kind of is lumped all together. I think people who are in public health and have a better understanding of what the social determinants are, how they impact different populations, and what some of the incidence is of different determinants on populations. They help to inform clinicians and people who do research in healthcare to look at something beyond what their particular specialty or area of expertise is. We tend to be very focused in on this population or this individual and their health status, whatever that health status piece is. We are less comfortable and sometimes less used to looking at what is the context, what is the impact of that context on that person's response. Whether we're talking about ability to cope, whether we're talking about their perception of subjective view of their well-being, or their response to that environmental or social or context. So helping us to look in a broader way at the influences and get more comfortable at always taking those into consideration is a strength that they bring. And helping us to better evaluate how what we do impacts their ability to cope and to master the challenges of their environment. So it's kind of an internal look, external look that we can bring together so that we're not missing anything. I tend to use the social determinants model because I engage with community a lot. So they don't come to me because something's wrong. I go to them looking at what it is and how they cope and what it is nursing or healthcare can bring to their environment to strengthen and empower them to do better at what they already are good at. So I look at the external, but that is not consistently what we're taught, to look at the environment and the external. So what public health can do is to help us do that better.
Thank you. I think, so many of us were trained to think in terms of individual interventions. And some of us have more experience and more training in terms of thinking about the community as opposed to the individual. And I think that what I hear a lot of people saying about what COVID has done is it tapped into the connection component within our communities in a way that maybe many of us didn't realize. And so I wanted to pose to the other panelists public health perspectives, community perspectives. Do you have additional thoughts or input you'd like to make? And Mike, I saw that you turned your camera on. Did you have a comment?
I know personally, as after 2020 and kind of, social isolation and going through the pandemic and just seeing a lot of social injustice, I was moved personally to do something about it. So that's kind of how Grow 502 was started, was when just started having conversations. And the one resource that the public health department has always released, but to me, I finally used it as a springboard to launch my ideas, was a Louisville Health Equity Report. And I think from all of us here, I think that report, and I'm not sure a lot of people understand how much work goes into it. That has a lot of information to get you started on whatever path you want to take when it comes to addressing a lot of these social determinants of health. It lists about 23 different health disparities from dental, mental, different somatic ailments that you can make an impact on, because it's not just gives you data about where it's located and how it's affecting the community. It also gives you resources, and it lists out specific determinants of health in specific areas of the city that are causing these issues, such as lack of sidewalks, lack of green space, predominance of tobacco stores and predominance of convenience stores compared to grocery stores. It just gives you all these different factors for you to learn about, as well as resources and organizations that are trying to help reduce that disparity. So if I could pinpoint any of the viewers and audience to something that helped them maybe get started, because they don't know where to really start this conversation, that report is phenomenal. That's actually how Grow 502 was started, was we used that report to create the whole series and launched our efforts into communities that are impacted by those health disparities. So I think that's one thing I could suggest.
That's a great point, Mike. Thanks. And we just put the link into the chat with respect to how you can access that health equity report. And you're right, that's a fabulous report. And it gives us a context for where we, as people in the community who are professional and want to get involved, how we might think better about the work that needs to be done. This question is for Holly. Holly, as community partners, how can we practice cultural sensitivity and grow our awareness to meet more unique needs of refugee and immigrant populations? And, I know that having worked in internal medicine and now in dentistry, and I'm a psychologist, so I've worked, kind of around town, but we work with refugees, and I wonder how can we get better? How can we partner? How can we be more culturally aware and sensitive? Where might we begin to think about this in the context of enhancing well-being?
Yeah, I think that that's a really good point, is that we all, no matter what line of work you do, interact with and encounter people who have come here through the process of seeking asylum and coming as refugees or immigrants. And so one thing is that it can be very overwhelming to try to like keep up with the news about things. So that feels a bit daunting. But if you can just hone in on some of the resources, for example, like KRM puts out resources and trainings pretty regularly to address, for example, right now, we've been sharing a lot of information about what's happening in Afghanistan, and we're getting new arrivals from there. And here's some things that you can know about these folks as they're coming to this country, being resettled here. And the same goes, for any of our communities that we work with. There are lots of online trainings and resources through the Kentucky Office for Refugees. If you go to their website, there's a lot of pre-recorded trainings and also live ones that you can sign up for in the future. And then I think more and more institutions are trying to implement some of those trainings for their staff as kind of part of the continuing education process. And so anytime if any of the places that people work, if you all are interested in getting any trainings organized for your place of employment, like, we at KRM are happy to help coordinate those things. Where I know I do trainings for mental health providers, specifically around culturally competent care, how to use an interpreter appropriately, that kind of thing. I know in the medical field, everyone has access to the language lines, but sometimes it can feel a little overwhelming or kind of clunky. So we also offer trainings on that, like how to kind of do that process a little bit better. So really just reaching out to your local organizations. So KRM and Catholic Charities of Louisville are the two resettlement agencies here in this area. And I know we'd be glad to connect folks with more training opportunities, but also if you're on social media and you just follow, any of these groups, like I said, the Kentucky Office for Refugee Resettlement as well. There's lots of things shared kind of through the Facebook page and other spaces like that too. So I think that's a good place to plug in.
And I want to mention too that we are going to be providing to everyone who came today a list of resources, and what Holly has just reviewed, what Mike has mentioned. I also want to ask Kaylin if you would like to weigh in on some resources that you think are particularly important, or areas of need that you see that we might be able to get involved in or connect people we know to. So I just want to note too that we put additional crisis information in the chat for you as well. And so, Kaylin, I don't know if you can hear me or if you have some thoughts or want to contribute. She may have stepped away for a moment because I know she is at work. So I'll turn it over to Dr. Heinz Martin with respect to what are you seeing where the needs might be? What do you feel like are communities, agencies, places that might need our attention, and where we might bring a greater awareness of well-being needs in our communities?
We have lots and lots of areas in which any one of the people that are here that want to contribute can find a place for themselves. What was identified by Mike was West Louisville. There's always lots and lots of things going on in West Louisville. South Louisville, in terms of many of our resettled refugees, have resources within those communities. But it basically has to do with what is it that you are interested in? Are you interested in the homeless population and where those people generally are? Sometimes Hotel Louisville is a place to go because we have a multidisciplinary kind of effort there. In fact, the library has a huge program at the Hotel Louisville that's focused in on literacy, computer literacy, and helping people find jobs, those kinds of things. One of the librarians at on Ekstrom has community outreach as her primary responsibility. So if I point to one, then I'm missing another. But what I have to, so the best bet is to say, what are you interested in? Who are you interested in? And then we can all point you in at least 2 or 3 different directions. So I would really encourage the people who are participating, who want to reach out into communities, to contact one of us, myself or one of the panelists, and say, I'm interested, I have this talent, where do you need me? So I think that's the way to go.
Thank you. And if you're not watching the chat, I encourage you to watch the chat, because periodically we have some things that are being put up, and we will share with you everything that we've had in the chat. I wanted to address another question to, really, I guess, to anybody on the panel, Dr. Heinz Martin. Many of us have trained as clinicians, and I mentioned that before. And you talked a little bit about this, but what do we as clinicians need to know to broaden our conceptualization of, it's not just mental illness, it's not just diagnosis. What is it that we need to know? What's the one take home you want us to have about thinking in terms of not just what's a diagnosis, but what is well-being, and why is that important?
The reason I had self-checks in my presentation was specifically for that reason. It's easier for people to identify struggles and things that impact them unexpectedly, but don't result in a mental health illness that's serious enough for treatment. But we've all experienced the stressors of this unfortunate situation. We've all seen things and had to think about things that we had not before. So if we take our own experiences and how we had to make adjustments and potentially talk to clients from that place, because that's a place that most clinicians had not been in before, then looking at people that's in a similar way is a way to begin to ask questions we would not ordinarily ask. And I think the bathe model that was identified is a good way to start. There's other ways, but that's a good short way to start, but also bringing our own experiences to the fact that we don't have a mental illness, but we certainly have struggled. And so talking to people about their struggles is a way to go.
I think that one of the things that we see every day is that there is a demand for mental health treatment that is almost tapping out the supply. And that through COVID, as Mike talked about, and Kaylin talked about, Holly has talked about, you've talked about, Dr. Heinz Martin, that, we're really seeking things out in a way that we haven't before. If we broaden our conceptualization, if we think more about, it's not just about the pathology, but it's about what we can do to raise the well-being of all, that has benefits, but we have to change our thinking. And so to that point, what is it that you think we as clinicians, we as teachers need to take home and think about and do better? And I just want to turn this over to each of our panelists. What do we need to think about differently? Mike, are you able to comment on that?
I think, it just obviously there has to be some context behind how this conversation gets brought up. But depending on what environment you're in, if it's from a teaching perspective, the number one thing we need to do is we need to talk about it. And it can't be just from a diagnosable aspect of mental health and well-being. We need to have some some more conversations and dialogue about the concept of well-being. And it needs to be a little bit more consistent instead of just maybe one lecture or one event around well-being, because I think that's how well-being is being treated, as like a one-time dose of, let me make sure I know what well-being is. And are you sleeping okay? Are you eating well? It's just a one-time conversation about these things. But instead, it needs to be an ongoing topic that's sprinkled into every aspect of patient care. Because end of the day, yes, in certain contexts, in certain time, in certain periods, when our patient, physician, patient, dentist, whatever provider patient interaction, you need to ask the patient how they are doing, because that's the only way to spur more conversation and for them to have a better connection. So if we're doing it more often and we're teaching it more often about, hey, before you even get into the meat and bones of this interaction, take 5 minutes to assess the patient on them as a human being. How are they doing? And I mean, I think that's the reason why I mentioned the bathe technique, because it's meant to be quick. There are it's used in family medicine practice to help, in that 30-minute interaction that doctors have with their patients that they're supposed to be allotted. It's a quick assessment tool to interview the patient and get needed information to see what their status is. However, it can definitely be adapted to any interaction. And I think once the best way for us to get to where we need to be is for us to start using it more and to teach it more to our students. Like, always address the patient in regards to their emotional well-being and make sure they're okay, because just that opening question can allow you to do your job more effectively and be more thorough. And I mean, I think that's the major point, because from my perspective in medical schools and medical students, we have to know the diagnosable illnesses. We have to know the extremes, because that would be malpractice to not be able to understand that. But it's not always going to be a patient coming in with these extremes, but a patient will always have an emotion. A patient will always be at some kind of mental health at some level of it. So I think the best way to teach it and make it more of a concrete thing we do in our interactions is to always come back to it. Always say, to start things off, focus on the patient as a person, and then move forward and do what you need to do to get through the interaction. But that's the only way it can become more of a concrete way of interacting, is we have to do it and we have to talk about it more often.
Thank you. I agree. So it really is about how we live our lives. And it's not always in the front of our minds in terms of the work that we do. So I'm going to go back to Kaylin. I know you had to step away. And so the question is, if you didn't hear it, what is it that we as providers, as teachers, as people who are working with communities, what's the one thing we need to do better in terms of thinking not just about diagnosable mental illness, but broadening our horizons to well-being?
I think with nursing in particular, we're taught to be nurturing and show compassion. And I feel like that is something that anybody should be exhibiting as well. I think empathy goes a long way. And I know we're not talking about just mental health. And although right now I work on inpatient psychiatry, so I am dealing with only mental health patients, but for the past 2 years, I've worked in corrections, and not everybody has a mental illness in that environment. And empathy goes a long way there. And I think just trying to put yourself in a patient's shoes or in their situation goes a long way and can definitely impact the type of care that we provide to those people. And so we're seeing them at one of the worst points, and we need to take that into account when we're treating them.
Thank you. Holly, did you want to add to that? What is something that we can do better?
Yeah, really similar to what Kaylin and Mike have already said, but As I think if we can be as holistic as possible in our approach, and to say that, overall well-being is not just about mental health, it's also social well-being, physical, how are we connected or disconnected? What is the bigger picture? What are those other things in our lives that are going on? And just trying to approach things through a holistic lens of looking at someone's life, not as one instance. Like if someone comes to me and they're upset, I'm not going to immediately say, oh, you're sad, you must be depressed. Instead, I'm going to learn more about their life and what they're coming in with, like what are those factors that are impacting them in that moment, and then to think holistically about how we can tend to that. What are the possible avenues of lessening that stress or whatever it may be, and then to go from there and to say that it's all a spectrum and it changes every day for people, and so just journeying alongside people through that.
Thank you. Dr. Heinz Martin, you talked about and you work a lot with community partnerships and collaborations. Is the practice of extending out to community partners and forming those partnerships something that we as within our discipline also need to improve on? And if so, where would we start?
I think anybody who works with people needs to collaborate with people. And the closer you collaborate with the people that are your target for care or support or services, the better you are at it. Because you don't count only on what you know clinically, you also use them for their areas of expertise. Their areas of expertise are the lived experiences of what it's like to be in that community, that population, that group. Sharing that responsibility in terms of making the care you provide more sensitive, more appropriate, and one in which people can invest, because people need to buy into something to make changes that they need to make. It's easier to buy into something that fits with what you already are, that fits with what you already value. And to me, that was the easier way. It was the easier way for me to say, I don't know it all, and I probably don't even know half of it. But with your help, we're going to come up with something really good. And you'd be surprised how well that works. That's why I do community engagement in all my roles. I have 3 roles at the university, and all of them have to do with community engagement, either within my integrated environmental health sciences center, with my work at the University School of Nursing, or with HSC. All of them have to do with my ability and my enthusiasm for identifying what people want, because they tell me what they want. And the previous question you just asked, which was, what is the core piece we need to be concerned with? Or how do we strive and address the things that we've been talking about in this session? I think we have to change the mindset of the providers. Nursing is really good at being adaptive and figuring out what people need, because that's part of how we're developed. But even with those who are really good at that, setting the priority that we don't have to talk to people about cardiovascular health being a critical issue and health promotion in that area being a critical issue. You don't have to sell it. You don't have to talk to people into it. We need to begin to set the agenda that emotional health and the promotion of emotional health is just as important, and set that agenda early on in people's development and in their beginning careers. So that when you say cardiovascular health and everybody is on board, you say emotional health and everybody's on board. And just changing our language and our messaging is going to be really important.
I was thinking as you were talking that we're all trained in silos, and so we sometimes don't even speak the same language, and yet we're all part of the same system serving the same communities. And that's something that many of us in our careers have had to learn later on. And for those of us who are educators, we can do a better job, I think. I'm talking about myself. I can do a better job of making sure that I integrate this into the conversation in terms of collaborative care and integrated models of care. I'm getting a little prompt here about watching our time, and we're about at the time where we need to wind up. And so I want to put it out to the group. If you have anything else that you'd like to put in the chat, or if you have a question that, we have a small enough group right now, we've had a few people have to leave. If you want to pose a question for any of our panelists, we're happy to take those questions. Just go ahead, and you're welcome to use the little button to wave, or or if you want to unmute and just ask, or if you want to pop something in the chat. We do have a couple of minutes. We can take advantage of the time we have with our panelists. There's a great deal of expertise and experience here. Anybody have anything they want to put out there or ask? Okay, why don't we go ahead and focus on winding up? I just want to thank each of our panelists for taking the time to be with us. This isn't easy to do. And one of the things that you mentioned is just the simple act of stopping what you're doing to show up and be here for a conversation like this is, extra. And we realize that, and we do very much appreciate it. Dr. Heinz Martin, I've seen you speak in a couple of venues, and I remember that you had done a presentation recently for Kentucky Psychological Association, and that's when I said, we need to ask her. So any last minute thoughts, suggestions as we wind up our evening here?
The only thought and suggestion I would have is, first, thank you so much for doing this session. I think it's a good starter. And I think the kinds of questions we've gotten and the dialogue we've gotten is a good place to start. I would hope that others who participated in this would find the opportunities to begin to explore how they can incorporate that into their work and in how they interact with community. And I'm hoping that you can reach out to any of the panelists and ask for their expertise and their assistance in moving forward in this work.
Fantastic. I also want to just remind you that we've had some things posted in the chat. We will be providing resources, both in terms of community resources, but also crisis numbers and resources. The Louisville Health and Wellness and Public Health area does really vibrant work, and I'm glad we have a link to that. And so with all of that said and my thanks expressed, I do want to turn it over to Vida Vaughn and everybody who is with the library to wind us up here. So thank you.
Thank you, Dr. Beecham. I just want to, again, express my thanks to our panel, Dr. Heinz Martin, Dr. Beecham, Mike, Kaylin, Holly. It's been wonderful to have. One thing that I do know with every person that was participating in this event on the panel is that they walk the talk, that they are each involved in their own ways in the community and the things that they're doing and trying to make that difference. And about a year ago, when the pandemic, social issues were going on, we were thinking, how can we make a difference? And as a librarians, information is our skill set, and we wanted to be able to facilitate conversations. And so we have been, this is the third one in a year, and I came to my team and said, the thing that I'm seeing across all the disciplines, as librarians, we work in public health, we work in nursing, we work in all the schools on the health science campus. And the one thing that I'm seeing that was a common thread across everything was the issue of wellness. And the struggles that people are going through, especially in the past couple of years, whether it's a refugee mother in OBGYN or a patient who's struggling with emotional issues, sitting in a dental chair. These are all things that the clinicians and students and residents are needing to understand as far as the evidence-based approach to care, which is a huge component of that Venn diagram, and that intersectionality is patients' values. And if we don't look at the entire wholeness of a patient, whatever specialty we're in, then we're not really doing the justice that we need. And each one of our participants have addressed that from their viewpoint and their perspective. And I just am so grateful for Dr. Beecham's moderating the evening. I'm so grateful for Dr. Heinz Martin taking the time, and for Holly and Kaylin and Mike, busy people in and of themselves, to be able to share this. And please send your information in. And if you have suggestions about other topics that we can address in the upcoming year as far as diversity in healthcare, please send me your thoughts, and we would certainly like to work with anybody who has an interest in going forward. So I will stop talking because I know that we've been going for a while here, but thank you to all of you who participated. And we're so grateful for the School of Medicine and the School of Dentistry to be able to help support us with giving this continuing education credits that gives you a little bit of a return on investment for your time. And am I giving it back to Gina, or are we saying goodnight to everyone and have a safe evening, and take care of yourself and those around you, and have those connections in whatever way we can.
Yes. Good night, everyone. Thank you for joining us.
Night. Thank you for coming.